Surgical management of congenital heart disease aims to achieve three primary goals. Anatomic correction restores normal cardiovascular structure, allowing optimal blood flow through both systemic and pulmonary circuits. Physiologic correction separates systemic and pulmonary circulations, preventing volume overload and preserving ventricular function. Palliation is considered when complete repair is not feasible, providing symptom relief and stabilizing the patient for future interventions. Biventricular repair is pursued when both ventricles are adequately sized and functional, enabling full circulatory correction. In contrast, univentricular palliation is selected when only a single ventricle can support systemic circulation, focusing on staged procedures to balance pulmonary and systemic blood flow while reducing volume load on the functional ventricle. Recognition of which strategy is appropriate depends on ventricular size, function, and associated anomalies, guiding the timing and type of surgical intervention. In neonates undergoing complex cardiac surgery, cardiopulmonary bypass assumes the work of the heart and lungs, maintaining oxygen delivery and perfusion while the heart is temporarily stopped. This supports a motionless, bloodless field for precise repair of congenital anomalies. Controlled hypothermia reduces metabolic demand and protects the brain, kidneys, and other organs from ischemic injury, which is particularly important in neonates due to their limited physiologic reserve. Deep hypothermic circulatory arrest is used when even minimal blood flow would obstruct critical repairs. Cooling to 15 to 18 degrees Celsius slows neonatal cellular metabolism, extending the safe duration of circulatory cessation. The arrest period is carefully limited, usually under 60 minutes, because prolonged interruption of circulation increases the risk of neurologic injury and organ dysfunction. Understanding these physiologic principles guides post-operative monitoring for perfusion, neurologic status, and organ function, allowing early recognition of complications specific to neonatal physiology. Preoperative planning in neonates with complex congenital heart disease begins with advanced imaging to define anatomy and physiology. Echocardiography provides real-time assessment of chamber size, ventricular function, and intracardiac shunts. Computed tomography and magnetic resonance imaging offer detailed structural information, particularly for extracardiac vessels and spatial relationships. Cardiac catheterization can measure pressures, assess pulmonary vascular resistance, and guide intervention planning. Three-dimensional modeling is increasingly used to visualize complex anatomy, helping the surgical team anticipate challenges and plan repair strategies. A multidisciplinary approach, involving the surgeon, cardiologist, anesthesiologist, and intensivist, ensures all physiologic considerations are addressed and perioperative risks minimized. Patient-specific factors such as prematurity, comorbidities, and ventricular function are integrated into risk stratification, informing timing and surgical strategy. Family counseling provides clear communication about expected outcomes, potential complications, and the staged nature of interventions, allowing parents to make informed decisions and prepare for postoperative care. Surgical timing in neonates and infants is determined by the balance between physiologic urgency and optimal developmental conditions. In the neonatal period, emergency repair is indicated for ductal-dependent lesions and obstructed total anomalous pulmonary venous return, where immediate restoration of systemic or pulmonary blood flow is critical. Transposition of the great arteries requires an arterial switch within the first weeks of life to prevent left ventricular regression, which would compromise the ventricle's ability to support systemic circulation. Hypoplastic left heart syndrome necessitates the Norwood procedure in the first week, establishing systemic output through staged palliation while the right ventricle assumes systemic workload. During infancy, elective timing allows for maturation and growth to improve surgical tolerance. Tetralogy of Fallot is typically repaired between 6 and 12 months, reducing cyanosis and preventing long-term right ventricular dysfunction. Truncus arteriosus repair within 6 to 12 months limits progression of pulmonary vascular disease. Single ventricle physiology patients undergo the Glenn shunt at 4 to 6 months, unloading the systemic ventricle and preparing for subsequent Fontan completion. Timing decisions integrate neonatal physiology, ventricular function, lesion complexity, and risk of early deterioration, ensuring interventions provide maximal benefit while minimizing perioperative complications. Balloon atrial septostomy is indicated in neonates with transposition of the great arteries when the atrial septum is restrictive and systemic, and pulmonary circulations are poorly mixed. In these patients, oxygen saturation is critically dependent on atrial level communication. The procedure serves as a temporizing measure, stabilizing oxygen delivery until definitive surgical repair can be performed. A catheter is introduced via the umbilical or femoral vein and advanced into the left atrium. A balloon is inflated and then rapidly withdrawn across the atrial septum, enlarging or creating an interatrial communication. This allows improved mixing of oxygenated and deoxygenated blood, which typically results in immediate increases in systemic oxygenation. Recognition of restrictive atrial septum and prompt intervention are crucial, as inadequate mixing can quickly lead to hypoxemia and organ dysfunction in the neonatal period. Single ventricle palliation involves a staged reconstruction to manage neonates in whom only one ventricle is capable of supporting systemic circulation. Stage 1, the Norwood procedure, is performed in the neonatal period to establish reliable systemic output while providing controlled pulmonary blood flow. Stage 2, the Glenn procedure, typically occurs at 4 to 6 months and connects the superior vena cava directly to the pulmonary arteries, reducing volume load on the single ventricle and preparing for passive pulmonary circulation. Stage 3, the Fontan procedure, performed between 2 and 4 years, completes separation of systemic and pulmonary circulations by routing inferior vena cava flow directly to the pulmonary arteries. The overarching goal of these stages is to optimize oxygen delivery while minimizing ventricular volume stress, ultimately creating a Fontan circulation where pulmonary blood flow occurs passively without ventricular pumping. Each stage is carefully timed to balance neonatal and infant growth, ventricular function, and pulmonary vascular development, reducing perioperative risk and enhancing long-term hemodynamic stability. The Norwood procedure is indicated in neonates with hypoplastic left heart syndrome or complex single ventricle lesions accompanied by systemic outflow obstruction. Its goal is to establish reliable systemic circulation while providing controlled pulmonary blood flow. Reconstruction of the aortic arch is performed using the pulmonary artery in the Damus-Kaye-Stansel configuration, creating a functional neoaorta capable of supplying the body. An atrial septectomy ensures unrestricted atrial level mixing, which is critical for maintaining systemic oxygen delivery in these patients. Pulmonary blood flow is provided through a systemic to pulmonary shunt, either a modified Blalock-Taussig shunt or a Sano conduit, balancing oxygenation without overloading the single ventricle. This procedure is considered the most complex and highest-risk cardiac surgery performed in the neonatal period due to the small size of structures, limited physiologic reserve, and potential for rapid hemodynamic instability. Meticulous perioperative management, including close monitoring of oxygenation, systemic perfusion, and ventricular function, is essential to optimize outcomes and reduce early mortality. The classical Norwood procedure uses a modified Blalock-Taussig shunt connecting the innominate artery to the pulmonary artery. This provides pulmonary blood flow, but increases volume load on the single ventricle, potentially contributing to ventricular dilation and reduced efficiency. The Sano modification replaces the systemic to pulmonary shunt with a right ventricle to pulmonary artery conduit, directing pulmonary flow more directly from the ventricle. This approach reduces volume load on the systemic ventricle and can improve early postoperative ventricular performance and hemodynamic stability. Selection between classical and Sano techniques is guided by ventricular function, patient size, and institutional outcomes data. Understanding these physiologic differences informs perioperative management, including inotropic support, fluid management, and oxygenation targets, and helps anticipate early postoperative complications related to ventricular loading and systemic perfusion. The Glenn shunt, or superior cavopulmonary connection, is the second stage in single ventricle palliation. In this procedure, the superior vena cava is connected directly to the pulmonary arteries, allowing venous blood from the upper body to flow passively into the lungs. The bidirectional Glenn ensures balanced perfusion of both lungs. This connection unloads the single ventricle, reducing volume stress and improving efficiency of systemic output. Oxygenation is enhanced compared to stage 1 because pulmonary blood flow is more directly matched to systemic venous return. Timing of the Glen is typically between 4 and 6 months of age, when pulmonary vascular resistance has physiologically decreased and the pulmonary arteries are of adequate size to accommodate passive flow. Careful assessment of pulmonary artery anatomy, ventricular function, and overall growth ensures that patients are optimized for this stage, reducing the risk of cyanosis, heart failure, and postoperative complications. The Fontan procedure, or total cavopulmonary connection, is the final stage of single ventricle palliation. In this procedure, the inferior vena cava is connected directly to the pulmonary arteries, completing the separation of systemic and pulmonary circulations. Following Fontan completion, the single ventricle is responsible solely for systemic output, while pulmonary blood flow occurs passively without ventricular pumping. Timing is typically between 2 and 4 years, allowing growth and maturation of the pulmonary vasculature and optimizing ventricular function. Hemodynamically, this configuration results in near-normal oxygen saturation, but systemic venous pressures are elevated and cardiac output is preload dependent. Understanding the physiologic consequences of Fontan circulation is critical for long-term management, including monitoring for exercise intolerance, arrhythmias, protein-losing enteropathy, and ventricular dysfunction, as these complications are driven by the unique circulation created by the staged palliation. Fontan circulation establishes a unique hemodynamic state in which pulmonary blood flow occurs passively without a pumping chamber. As a result, systemic venous pressures are chronically elevated, and overall cardiac output is reduced compared to normal biventricular physiology. These physiologic changes place ongoing stress on the single ventricle and other organ systems. Long-term, arrhythmias are common due to atrial dilation and surgical scarring, and protein-losing enteropathy may develop from elevated venous pressures and lymphatic congestion. Patients are also at increased risk for thromboembolic events, reflecting sluggish venous flow and altered coagulation dynamics. Exercise intolerance is frequently observed because cardiac output cannot increase substantially during activity. Many patients require lifelong anticoagulation or antiplatelet therapy to mitigate thrombotic risk, and close longitudinal monitoring is necessary to identify early ventricular dysfunction, arrhythmia, or other complications. Understanding these physiologic principles is essential for anticipating long-term clinical challenges and guiding interventions to maintain optimal functional status. The arterial switch operation, or Jetain procedure, is the preferred repair for neonates with transposition of the great arteries. This procedure provides true anatomic correction, resulting in the best long-term outcomes for systemic and pulmonary circulation. The operation involves switching the aorta and pulmonary artery to connect each vessel to its corresponding ventricle, restoring normal physiologic flow. The coronary arteries are then transferred to the neo-aorta, representing the most technically challenging component due to the small size and delicate nature of neonatal coronary vessels. Timing is critical. The operation must be performed within the first few weeks of life before left ventricular pressure falls, as a regressed left ventricle may be unable to support systemic circulation. Recognizing early which neonates require arterial switch and monitoring ventricular function are essential to ensure successful surgical outcomes and minimize perioperative complications. Coronary artery anatomy plays a critical role in the arterial switch operation, as neonatal coronary patterns vary significantly and influence surgical complexity. Multiple patterns have been described, including the Leiden classification, with some configurations presenting higher technical challenges due to short or intramural courses that increase the risk of coronary compromise. Successful transfer requires meticulous handling to maintain patency and prevent kinking or obstruction, which could lead to myocardial ischemia. Adequate left ventricular pressure, typically greater than 2/3 of systemic levels, and preserved left ventricular function are prerequisites for surgery, ensuring the ventricle can sustain systemic circulation post-repair. Preoperative imaging and careful intraoperative assessment guide the surgeon in evaluating coronary anatomy and ventricular readiness, directly impacting surgical planning and post-operative outcomes in these neonates. The Damus-Kaye-Stansel procedure is indicated in neonates with complex outflow tract obstruction or single ventricle lesions complicated by subaortic stenosis. It is often a component of the Norwood procedure, providing unobstructed systemic blood flow. The operation involves anastomosing the pulmonary artery to the ascending aorta, effectively creating a single, continuous outflow tract from the ventricle to the systemic circulation. This relieves obstruction at the level of the left ventricular outflow tract or the hypoplastic aortic arch. The procedure is frequently combined with atrial septectomy or systemic to pulmonary shunting to optimize oxygen delivery and ventricular workload. In neonates, this approach stabilizes systemic perfusion while maintaining controlled pulmonary blood flow, forming a critical foundation for subsequent staged palliation or repair. Surgical management of Ebstein's anomaly in neonates focuses on restoring effective right ventricular function and improving systemic and pulmonary blood flow. Tricuspid valve repair is preferred when feasible, with techniques such as cone reconstruction or plication aimed at restoring valve leaflet coaptation and reducing regurgitation. When repair is not possible due to severe leaflet malformation, tricuspid valve replacement may be necessary, though long-term outcomes are generally less favorable. Right ventricular plication is used to reduce the atrialized portion of the ventricle, improving contractile efficiency and reducing volume overload. Closure of any associated atrial septal defect ensures that right-to-left shunting does not compromise systemic oxygenation. Outcomes vary according to the degree of valve malformation and ventricular function at presentation, with repair generally resulting in better long-term hemodynamics than replacement. Many neonates require staged or repeat interventions as the right ventricle remodels and grows, highlighting the importance of ongoing assessment of ventricular function, valve competence, and systemic oxygenation. Surgical management of pulmonary atresia with right ventricular outflow tract obstruction in neonates focuses on establishing reliable pulmonary blood flow while preserving right ventricular function. Reconstruction often involves placement of a right ventricle to pulmonary artery conduit, which may be valved or non-valved depending on the patient's anatomy and anticipated growth. When feasible, pulmonary valve reconstruction can restore native valve function and reduce long-term conduit dependence. In cases with multiple aortopulmonary collaterals, unifocalization is performed to integrate these vessels into a centralized pulmonary artery system, optimizing pulmonary perfusion and reducing cyanosis. Conduit selection is influenced by growth potential. Biologic conduits are preferred for compatibility with somatic growth, although mechanical options may be considered in specific scenarios. Multiple conduit replacements are anticipated as the child grows. Emerging percutaneous valve replacement techniques may reduce the number of open surgical interventions, though these are typically reserved for later stages. Understanding these strategies guides monitoring of oxygenation, right ventricular workload, and timing of reintervention throughout infancy and early childhood. The Ross procedure is indicated in neonates and infants with severe aortic valve disease or complex left heart obstruction, where conventional valve repair or replacement may be insufficient. The operation involves transferring the patient's pulmonary valve to the aortic position, creating a living autograft capable of supporting systemic circulation. A pulmonary homograft is then placed in the right ventricular outflow tract to restore pulmonary blood flow, completing the so-called double switch. The use of the patient's own pulmonary valve allows for somatic growth, which is particularly advantageous in neonates and young infants, reducing the need for early reintervention. Additionally, this autograft strategy eliminates the requirement for long-term anticoagulation, which is challenging in the neonatal period. Careful assessment of left ventricular function, outflow tract size, and pulmonary artery anatomy guides patient selection and timing, and postoperative monitoring focuses on ventricular performance, conduit function, and systemic perfusion. Surgical repair of double outlet right ventricle in neonates depends on ventricular septal defect location and overall anatomy. When the VSD is subaortic, a simple intraventricular baffle or closure may align the left ventricle with the aorta, enabling a relatively straightforward biventricular repair. Subpulmonary VSDS may require an arterial switch to connect the left ventricle to the aorta, ensuring physiologic systemic output. Remote or non-committed VSDs often necessitate more complex intracardiac baffling or, when biventricular alignment is not feasible, single ventricle palliation. Biventricular repair is preferred whenever anatomy allows, preserving two-ventricle physiology and optimizing long-term outcomes. When a biventricular approach is not possible, staged single ventricle procedures balance systemic and pulmonary circulations, reduce ventricular workload, and maintain adequate oxygenation. Close evaluation of VSD location, ventricular function, and outflow tract alignment guides surgical planning and perioperative management in neonates. Heterotaxy syndromes in neonates involve complex and variable anatomy, including abnormal arrangement of thoraco-abdominal organs and cardiac structures. Visceral abnormalities, such as malpositioned liver or stomach, influence surgical access and cannulation strategies, while variable cardiac anatomy necessitates individualized operative planning. Splenic anomalies, including asplenia or polysplenia, increase susceptibility to infection and impact perioperative prophylaxis and immunization strategies. Surgical correction often requires a staged approach, tailored to the patient's unique anatomy and physiologic capacity. These cases carry high morbidity and mortality due to the combination of complex cardiovascular lesions, organ system involvement, and potential for post-operative complications such as arrhythmias, ventricular dysfunction, and sepsis. Close preoperative assessment of cardiac morphology, organ arrangement, and immune function is essential to optimize timing, surgical strategy, and post-operative management. Hybrid Norwood procedures combine surgical and catheter-based techniques to stabilize neonates with complex single ventricle lesions. Bilateral pulmonary artery bands limit pulmonary overcirculation, while a ductal stent maintains systemic blood flow, avoiding the need for immediate cardiopulmonary bypass. This approach reduces the physiologic stress of a full Norwood in the neonatal period, which is particularly beneficial for small or high-risk infants. Despite the initial less invasive strategy, stage 2 surgery remains necessary to complete the single ventricle palliation pathway. The primary advantage of the hybrid approach is that it provides a smaller initial operation while preserving systemic output and oxygenation, allowing the ventricle and pulmonary vasculature to grow before more extensive reconstruction. Careful monitoring of oxygenation, pulmonary artery pressures, and ductal stent patency is critical during the interstage period to optimize outcomes. Mechanical circulatory support plays a critical role in neonates undergoing complex cardiac surgery. Extracorporeal membrane oxygenation can serve as a bridge to surgery in unstable patients, providing oxygen delivery and systemic perfusion while definitive repair is planned. It is also used perioperatively for high-risk procedures to support hemodynamics and oxygenation, or as rescue therapy when a neonate cannot be weaned from cardiopulmonary bypass. Ventricular assist devices may provide support for end-stage heart failure, either as a bridge to transplant or, in select cases, as a bridge to recovery. In neonates, their use is limited by patient size, cannula availability, and technical challenges, requiring specialized expertise. Selection of support modality depends on ventricular function, hemodynamic stability, and anticipated duration of support, with continuous monitoring of perfusion, oxygenation, and end organ function guiding management. Low cardiac output syndrome occurs in neonates within the first 6 to 24 hours after cardiac surgery when systemic perfusion is inadequate to meet metabolic demands. It is a common complication following complex neonatal procedures. Contributing factors include myocardial stunning from cardiopulmonary bypass, insufficient myocardial protection during surgery, residual anatomic lesions, and arrhythmias that impair effective ventricular contraction. Clinically, neonates may present with hypotension, poor perfusion, oliguria, metabolic acidosis, and rising lactate levels. Management focuses on optimizing ventricular performance and systemic perfusion. Inotropic agents support contractility, while afterload reduction facilitates forward flow from the ventricle. In cases refractory to medical therapy, extracorporeal membrane oxygenation provides temporary circulatory support until myocardial recovery or corrective interventions can be performed. Prompt recognition and tailored support are essential to prevent end organ injury and stabilize hemodynamics in the immediate postoperative period. Postoperative arrhythmias are frequent in neonates following cardiac surgery due to the immaturity of the conduction system and surgical manipulation. Junctional ectopic tachycardia is the most common arrhythmia, often associated with surgery near the atrioventricular node or his bundle, leading to loss of atrioventricular synchrony and reduced cardiac output. Atrial flutter or fibrillation may occur, particularly in the setting of atrial enlargement or manipulation, resulting in rapid ventricular rates and compromised systemic perfusion. Heart block, temporary or permanent, can result from trauma to the conduction tissue during repair. Ventricular arrhythmias, though less common, may arise from ischemia, electrolyte disturbances, or myocardial injury. Risk factors include surgical proximity to the conduction system, electrolyte imbalances such as hypokalemia or hypomagnesemia, perioperative hypothermia, and medications that affect conduction. Early recognition and intervention are critical. Management may include electrolyte correction, antiarrhythmic therapy, temporary pacing, or, in persistent cases, permanent pacemaker placement. Junctional ectopic tachycardia is a narrow complex tachycardia originating from the atrioventricular junction and is commonly observed in neonates following complex congenital heart surgery. Heart rates typically range from 170 to 250 beats per minute, and atrioventricular dissociation can reduce effective cardiac output, placing additional stress on the recovering myocardium. Management strategies focus on stabilizing hemodynamics and suppressing arrhythmia. Mild therapeutic cooling to 35 to 36 degrees Celsius reduces metabolic demand and myocardial excitability. Amiodarone infusion is frequently used to control rate and restore coordinated contraction. Temporary pacing may be necessary in cases of significant AV dissociation to maintain synchronized ventricular activity. JET in neonates is usually self-limited, resolving within 24 to 72 hours, but careful monitoring of perfusion, blood pressure, and oxygenation is essential during the acute phase to prevent secondary organ injury. Heart block is a recognized complication following neonatal cardiac surgery and may be temporary or permanent. Temporary heart block typically results from localized edema or surgical trauma to the conduction system and often resolves spontaneously within days. Permanent heart block occurs when the conduction tissue sustains irreversible injury, necessitating placement of a permanent pacemaker. Procedures with higher risk include ventricular septal defect closure, atrioventricular canal repair, and tricuspid valve surgery due to proximity to the atrioventricular node and his bundle. Management involves routine placement of temporary pacing wires during surgery to provide immediate support if needed. Observation for 7 to 10 days allows resolution of transient block before committing to a permanent device. During this period, close monitoring of heart rate, perfusion, and rhythm is essential to prevent hemodynamic compromise while determining whether permanent pacing is required. Postoperative complications in neonates after cardiac surgery extend beyond low cardiac output and arrhythmias. Bleeding can occur due to coagulopathy from cardiopulmonary bypass or direct surgical trauma, sometimes necessitating re-exploration to control hemorrhage. Pulmonary hypertensive crises result from elevated pulmonary vascular resistance, which increases right ventricular afterload and can precipitate right heart failure. Management includes sedation to reduce metabolic demand, controlled hyperventilation to lower pulmonary pressures, and inhaled nitric oxide to achieve selective pulmonary vasodilation. Chylothorax arises from disruption of lymphatic channels during surgery, leading to accumulation of lymphatic fluid in the pleural space. Management involves dietary modification to reduce lymph flow, with medium-chain triglyceride formulas or total parenteral nutrition, and in refractory cases, surgical intervention may be required to repair the lymphatic leak. Early recognition of these complications, prompt supportive therapy, and close monitoring of hemodynamics, oxygenation, and fluid balance are critical to optimize recovery in neonates. Long-term survival following neonatal cardiac surgery has improved substantially over recent decades due to advances in surgical technique, perioperative care, and postoperative monitoring. Survival is highly dependent on the specific lesion, anatomic complexity, and associated comorbidities. For neonates with transposition of the great arteries who undergo an arterial switch operation, long-term survival exceeds 95%, reflecting durable anatomic correction. Tetralogy of Fallot repair also demonstrates excellent outcomes, with 90 to 95% long-term survival in most series. Hypoplastic left heart syndrome managed through staged Fontan palliation carries a more guarded prognosis, with 60 to 80% survival to Fontan completion, reflecting the physiologic challenges and risk of interstage complications. Complex lesions, particularly those involving multiple ventricles or heterotaxy syndromes, exhibit variable outcomes and often necessitate multiple surgical or catheter-based interventions. Tracking lesion-specific survival and monitoring for long-term complications such as arrhythmias, ventricular dysfunction, or reinterventions are essential components of follow-up in this population. Long-term functional outcomes after neonatal cardiac surgery vary according to lesion complexity and the type of repair performed. Most patients experience some limitation in exercise capacity, with the greatest restrictions seen in Fontan physiology due to passive pulmonary circulation and reduced cardiac output. In contrast, children with simpler lesions, such as repaired tetralogy of Fallot or transposition of the great arteries after arterial switch, typically achieve near normal exercise tolerance. Quality of life is generally favorable for most survivors, though psychosocial support is critical for both patients and families to address the emotional and developmental challenges associated with chronic cardiac conditions. Lifelong follow-up with pediatric cardiology is essential to monitor ventricular function, detect late arrhythmias, evaluate exercise capacity, and guide timely interventions, ensuring the best possible long-term functional outcomes. Reintervention is common in children who have undergone neonatal cardiac surgery, primarily due to the growing size of the patient and evolving physiology. Conduits placed during early repairs may require replacement as the child grows, and valves can develop stenosis or regurgitation over time, necessitating repeat intervention. Arrhythmias may emerge months to years post-operatively, sometimes requiring catheter-based electrophysiology procedures. Residual lesions that were not fully addressed during the initial surgery can also prompt reintervention to optimize hemodynamics and oxygen delivery. Percutaneous techniques are increasingly used to reduce surgical burden, including balloon dilation of stenotic vessels, stent placement for obstructed pulmonary arteries or systemic veins, and emerging percutaneous valve replacement. These interventions allow maintenance of circulatory function and ventricular efficiency while delaying or reducing the need for repeat open heart surgery. Close longitudinal surveillance with imaging, functional assessment, and electrocardiography guides timely intervention and optimizes long-term outcomes. Neurodevelopmental outcomes are an important consideration for neonates undergoing cardiac surgery. Risk factors include preoperative hypoxemia, prolonged cardiopulmonary bypass, deep hypothermic circulatory arrest, and postoperative complications such as low cardiac output or arrhythmias, all of which can impair cerebral oxygen delivery and disrupt normal brain development. Among survivors of complex congenital heart disease, 20 to 30% may experience learning disabilities. Other common neurodevelopmental challenges include attention deficits, fine motor difficulties, and speech or language delays. Early recognition through structured developmental assessments allows targeted interventions, such as occupational, physical, or speech therapy. Longitudinal monitoring supports optimized cognitive, motor, and communication outcomes, emphasizing the importance of integrating neurodevelopmental surveillance into routine follow-up for high-risk neonatal cardiac patients. Neuroprotection during and after neonatal cardiac surgery focuses on preserving cerebral oxygen delivery and minimizing injury. Intraoperatively, strategies include minimizing cardiopulmonary bypass and deep hypothermic circulatory arrest duration, optimizing perfusion to ensure adequate cerebral blood flow, and carefully managing temperature to balance metabolic demand and organ protection. Post-operatively, avoiding hypotension and maintaining sufficient oxygenation are essential to prevent secondary cerebral injury. Early developmental support, including gentle stimulation and mobilization when feasible, promotes neurocognitive recovery and helps mitigate the impact of perioperative stress. These measures, applied consistently throughout the perioperative period, are critical to improving long-term neurodevelopmental outcomes in high-risk neonatal cardiac patients. The neonatal intensive care unit plays a central role in the perioperative care of neonates undergoing cardiac surgery. Preoperatively, stabilization of critically ill infants is essential, including optimization of oxygenation, ventilation, and perfusion, as well as correction of electrolyte and metabolic imbalances. Supporting the family through education about the planned procedure, anticipated outcomes, and potential complications is equally important. Postoperatively, intensive hemodynamic monitoring and tailored support help maintain systemic perfusion and oxygen delivery. Early recognition of complications, including low cardiac output, arrhythmias, bleeding, or pulmonary hypertensive crises, is critical for timely intervention. Coordination with the cardiac, surgical, and cardiology teams ensures integrated management, while continued developmental support and family involvement promote neurocognitive and emotional well-being. This comprehensive approach helps maximize surgical outcomes and supports recovery in this high-risk neonatal population. Early surgical intervention in neonates with complex congenital heart disease frequently improves outcomes by preventing prolonged hypoxemia, ventricular volume overload, or end-organ injury. Complications are common in this population, and maintaining a high index of suspicion for low cardiac output, arrhythmias, bleeding, or pulmonary hypertensive crises is essential for timely management. A multidisciplinary approach, including neonatology, cardiology, cardiac surgery, anesthesiology, and nursing, is critical to coordinate perioperative care and optimize physiologic stability. Family counseling provides clear communication regarding realistic long-term expectations, the need for multiple procedures, and ongoing developmental support. Lifelong cardiology follow-up is required for all patients with congenital heart disease to monitor ventricular function, valve competence, and rhythm, and to plan timely reinterventions. Routine neurodevelopmental screening allows early identification of cognitive, motor, or language deficits, enabling prompt therapeutic intervention and improving long-term functional outcomes. Modern congenital heart surgery provides life-saving interventions for neonates with conditions that were previously fatal, offering markedly improved survival and functional outcomes. These procedures are often complex and require specialized surgical expertise, advanced perioperative support, and careful planning for long-term management. NICU clinicians play a critical role by understanding surgical timing and indications, anticipating and managing post-operative complications such as low cardiac output, arrhythmias, or pulmonary hypertensive crises, and supporting long-term outcomes including ventricular function, exercise capacity, and neurodevelopment. Coordinated care across surgery, cardiology, anesthesia, and intensive care teams, combined with active family engagement and education, is essential to optimize recovery and ensure sustained physiologic stability. Expert surgical repair alone is insufficient. Outcomes are maximized when perioperative and long-term care are seamlessly integrated for each neonatal patient.